Hi, everyone. Thank you for joining us. I'm Katie Sacra, Director of Family Programs here at the GFPD, and I will be your host for tonight's webinar, Portrait of the Prospective Vision Study. It is my pleasure to introduce both Dr. Alex Levin and Frederique Arnaud, who will be with us this evening to share about this important vision study, including updates and a Q&A session with both of them. Please go ahead and submit your questions at any time throughout the webinar. During the presentation, if a question comes to you, you can go ahead and submit it in the box located beneath the webinar player window, or I'll be monitoring the chat box with assistance from Ryan Maple, so feel free to use that chat box to submit questions too. Presenting tonight will be Frederique Arnaud, who studied and worked as a nurse and now coordinates clinical research studies as the Research Institute of McGill University Health Center in Montreal. She is passionate about clinical research for rare diseases and joined Dr. Nancy Braverman's team 2 years ago. She is the coordinator for the longitudinal prospective natural history study of retinopathy and Zellweger spectrum disorder, a precursor study for developing a retinal gene therapy trial. Frederique is experienced in coordinating rare disease studies and is familiar with some of the challenges related to collecting data from families navigating the complexities of rare diseases. In the context of study visits, she worked with 10 or so families of GFPD warriors. Also joining us this evening is Dr. Alex Levin. Following the completion of pediatric residency at the Children's Hospital of Philadelphia, Dr. Levin was a child abuse pediatrician. He then completed an ophthalmology residency at Wills Eye Hospital in Philadelphia, followed by a pediatric ophthalmology fellowship at the Hospital for Sick Children in Toronto, where he returned to become professor in the Department of Pediatrics, Genetics, and Ophthalmology and Vision Services at the University of Toronto, while working as a staff ophthalmologist at the Hospital for Sick Children for over 16 years. There, he started the Ocular Genetics program in 1995 with Dr. Brenda Galley. In 2008, he returned to Wills as the Chief of Pediatric Ophthalmology and Ocular Genetics and professor at the Sidney Kimmel Medical College of Thomas Jefferson University. There, he established a new ocular genetics program. He is now the Chief of Pediatric Ophthalmology and Ocular Genetics at the Flaum Eye Institute and Golisano Children's Hospital, as well as the Chief of Clinical Genetics at the University of Rochester Medical Center in New York. He has published 320 papers in peer-reviewed journals, 163 book chapters, and 13 books. He has delivered over 1,635 lectures and presentations nationally and internationally. He serves on the executive committee of the International Society of Eye Disease and Retinoblastoma, and has held or holds leadership positions for many family groups devoted to rare genetic disorders. He is a member of the AAPOS Genetics Task Force. As a member of their medical advisory committee, he is spearheading the efforts of Orbis to improve ocular genetics education and services internationally. His center is an approved Luxturna site and also involved in several gene therapy projects, gene agnostic clinical trials, and working closely with the Institute for Vision Research at Iowa to develop low-cost, open-access, non-patented gene therapy for retinal dystrophies. He has been working as an ocular geneticist for over 30 years and has been a member of ISGEDR since the early 1990s. Thank you both for being here tonight to share with all of us. Frederique, I will now turn it over to you.
Thank you, Katie. It's a pleasure to be joining you tonight for the presentation on the Portrait of a Prospective Vision Study. I really appreciate the invite, and I welcome all of you, parents, families who have decided to join us. So during this webinar, you will gain knowledge about the study. If you haven't heard me talk about it at the GFPD meeting last year, I had covered a little bit of what we were doing, and I will cover some more. You'll hear what you need to do in order to participate in the study, and then we will go through some very practical aspects of coming for a study visit so that you may have an idea of what it takes. And then I will cover a little bit of the data that we've collected so far. We've worked on the study for a couple of years, but we've seen patients for 1 year. So we have one set of data for these patients, and I'll cover a little bit of that. And then you'll hear about the opening of a new study site with Dr. Levin, actually, and we'll have the opportunity to ask your questions towards the end if you have any, and we'll be glad to cover to answer them. Dr. Levin will jump in if there's any things that I'm not covering in the right way, and otherwise we'll be more than happy to answer the questions also at the end. He, after all, is the expert on the on both subjects of genetics and ophthalmology. So for a little bit of background, Dr. Braverman's lab has worked with a mouse model to successfully create a gene therapy. And we now hope to translate this knowledge to a human retinal gene therapy. Now, this seems that we're kind of halfway there, which we are, and this study is really part of the process to get all the way there to the actual clinical trials for human gene therapy. So our scientists, in order to get to that point of the clinical trials in humans, we need to know how and when in the disease process intervention would be the most likely to succeed, and especially have the most positive impact. And that requires a better understanding of what the normal disease process involves and the impacts it has on vision in general and people's function in everyday life. And so we are collecting very rigorously data on all sorts of aspects of the eye, the retina, the nerve, and to see the evolution of the disease without any treatment or with the treatments that we know so far. And we are collecting information in order to, again, find where and when is the ideal time to start a gene therapy, let's say, when we get to that point. And then this data, of course, is crucial not only for gene therapy, but actually will be useful to many other therapy trials when it gets to that point for any other therapies. So as reported in the externally led patient-focused drug development meeting of last year's GFPD meeting, vision loss is one of the most impactful symptoms of the peroxisomal biogenesis disorder patients. And it totally makes sense. We have gotten used, we who are seeing things as most people do, are totally used to that, and we don't necessarily realize how difficult it is to navigate the world without that vision, but we do imagine that it would be very difficult. And this is certainly why Dr. Braverman has decided that this is a focus of her research. And then after the natural history study, which collects all the information about all the aspects of the disease, now we have progressed to really focusing on the vision, the damage to the eyes, what it does, how it does it, and why it does it. So that's the focus of the research that we are talking about at this meeting tonight. So who can participate in this study? We are looking for people who have confirmed ZSD diagnosis, and we need to, while we certainly would appreciate to know the exact PEX mutation that has been identified, because we need to exclude the more severe form of the disease, because for very obvious reasons that the patients would be just simply too sick to be able to really participate in the assessments. And we have gathered that the PEX2, the PEX10, 12, and 16 generally do not develop retinal pathologies, and therefore we are not looking necessarily for these patients. However, if there were signs that there is some retinal involvement from these patients, we would be totally open to amending our protocol and to start and evaluate such patients. We hope to collect data from about 30 participants altogether. At the moment, we are close to 15 at McGill, and we're hoping to get to about 20. And then Dr. Levin would take on another 10 patients. Now, if we have more in the end, that's great. The more the merrier, but we need at least 30. So that's our bottom line. And what we do in general is that we exchange with interested parties before arranging any visits so that we can estimate if it's feasible, how much difficulty it would be for families to come to us, whether it's worth it, how many tests we can do, and how much trouble it would be for your families, and whether it's worth it for you as well to participate. So this is an exchange we have before we even get into the study, but this is a conversation that we are very open to having in order to minimize, the trouble it takes to participate. What you need to do is to travel to the sites. There's 2 sites, as I have said. There's McGill in Montreal, and there's Rochester in Rochester. And we would ask you to travel to us once a year for a total of 3 to 4 years, depending on how quickly we get to be able to see you. Our study has been sponsored for 5 years, and we are already running into our second year. So this is why if we 3 to 4 years remain basically for collecting data for us. Rochester University is almost approved. Dr. Levin will have possibly more to say about that. They're almost approved by their research compliance team, and we've been working at making sure that the logistics are ready and that we have covered all the administrative aspects of it, so that when the approval comes through, we can go right ahead and start having patients not too long after that. And Dr. Levin has agreed to supervise the study there. We will do all the same tests at McGill and at Rochester, and we will put all our data together at the end and analyze it. The McGill site will refer some participants to Rochester if needed, or people can call Rochester directly, and depending on where we're at in terms of numbers, we might encourage you to one side or the other, but other than that, it's really up to you what you prefer, where you prefer to go. In very practical terms, most people will end up traveling. Not too many people live very close. So we will help you go through, arrangements for travel and hotel arrangements, but we ask that the families make the final decisions and arrangement themselves so that they get what suits them best. We have a family who was very generous and helped us create a couple of slides about help from Canada. Air Canada, for example, has special rates for people traveling with disabilities and their support persons. So things like that we can help you with, but at the end, you still have to make the arrangements, the final arrangements. And then in order to give you an idea, more general idea, the study visit really can take up to a whole day. So depending on how many tests you'll be able to do, or your warrior will be able to do, it would take up to a full day. Sometimes it only takes a couple of hours. It really depends how many tests are feasible for the participant. And that's why we talk to you before the visit, just also in order to organize ourselves and also to prepare you for what to expect. If you were one of these families where the participant could do the whole battery of tests, then we could, if necessary, spread it over a couple of days to make it a little easier on both the family and the participant. It depends on the families. Some people prefer to do everything on one day and then rest for the next, or spread it out so that there is a chance to kind of catch up. And of course, we'll take breaks as necessary to get the maximum participation from your warriors. At McGill, and I can only speak of McGill at the moment because I don't know the details of Dr. Levin's team at, yet. We're just starting to get to know each other a little more. So at McGill, our technician Mona has a lot of research experience with children as well as adults, and she is gaining more experience with ZSD patients in particular. She's now tested 12 patients. We have 3 more that are just about to be tested. She has nearly endless patience and perseverance, which has been really great with both the participants, and for us, it's great because, she will try to find a way to get the data that we really appreciate you bringing to us, really. And the families know their warriors best. So, any knowledge from you to help us make them comfortable and cooperative, of course, is very much appreciated. And we will try our best to make them cooperative is the best word, because it's really a collaboration at this point, between the scientists and the families. And we really appreciate that you make such a big effort to come to us. And so we will make probably all our efforts to make it work for you. So during the initial contact, again, prior to the first visit, let us know if you have special needs. We need to know, of course, the general health of your warriors so we can prepare accordingly. And anything that can help us make the visit smooth, we'll be happy to discuss. Some of the tests are a little longer. Some of the tests are a little more challenging because it requires a certain coordination or things like that. For example, the test when we test the visual field in particular, it's the one that comes up to mind, is there is a flash. The person has to react to the flash by clicking something, and sometimes it takes a while, especially for our warriors, to connect. They actually do see the flash, but it takes a certain time to realize that they have to click on the what they're holding. And so what we do is we really slow things down. This is one of the things we've learned over the year, is that we started off doing the regular test, but we noticed that some participants actually did see the flash, but they didn't have a chance before the next flash to react to it. So we really slowed it down to make it, a vision test as opposed to a reaction test, let's say. The data itself, well, as I just said, we have adapted some of the ways we collect the data to make it better. We collect data on the eye, especially, of course, the retina and the optic nerve. We test the vision in general, and we also test the impact on the daily activities for the participant as well as for the families. Some of the tests are clinically approved for standard care, so you will have seen them and done them with your care providers, and other tests are really done only on a research basis. So, and these tests are, because they are only done on research basis, we are still trying to evaluate what aspects of the test we can use for, in our case in particular. And Dr. Levin can expand on that when we come to that later. So we'll show you some of the data that we collect for some of the tests. So we, for example, will take pictures of the retina and optic nerve, and we can measure the optic nerve, and that gives us information on, the damage, what it can do, what it should be doing with that particular measurement. We have photos that give us more of a descriptive result. So for instance, in this particular picture, you see a lot of dark spots. These are called hyperpigmentation or pigment clumps, and these indicate a certain loss of vision in those particular areas. So that gives an idea of why the person has limited vision, for instance. In the optical coherence tomography test, we call the OCT, we can visualize the cross section or the thickness of the retina, and that gives us different information. It shows, for instance, if you see here, the top picture on the left is the quote unquote normal retina with all its layers properly aligned and whatnot. And this on the right is the damaged retina in a ZSD patient, where we see what's called schitic spaces, which reveals some edema in the macula, for instance. And again, this gives us an indication of where the damage is and why the vision is affected. So one of the tests is called the visual field. There are different ways of testing for visual field. So sometimes we do just one eye at a time, and it gives us an idea, a very precise idea of each eye and each region of the eye, what the damage is peripherally. For a lot of the younger patients, we've tested both eyes together, and that gives us a different idea, but it shows us where the damage is in a very concrete way. The color vision test, I'm sure a lot of you have seen it. It's done everywhere, and that over time we will see if there is a difference. I will speak in the future because we haven't seen too many people yet 2 years in a row. So, but if there is a difference, we will see over time. Then there's the contrast sensitivity test, where that's tested one eye at a time, and that's tested in a room that's regular lighting, and it's to see how far we can the participant can detect the contrast, basically. So on the right side is our little chart that we keep track of how many letters can be read, and then we do a few calculations, and again over time we will see a difference or not in the readings. And then finally we have, or not finally, there are other tests. I didn't cover absolutely everything, but finally we have the questionnaires that give us a very functional vision impact. There are questions about everyday life. For instance, how do your eyes make it hard to learn? So this is a question for a child or an adolescent. How does your eye make it hard? Does your eye disease, I guess, make it hard to learn, for instance? Whereas the patient questionnaire may be something like, how often does your participant's eye disease affect your family life? How does it affect your family life? There's different ways of finding out the practical impacts of the vision loss, both at the participants level and at the family level, which we are hoping will give us a better idea, a better grasp of what the impact is in general. So far, we are 1 year into the study. We've reviewed the data and made some adjustments. We have made adjustments, especially in how we record and exactly what data points we think are going to be most interesting. And what we're going to do is every year we're going to have a review and see if what we have so far is useful to the purpose of our study. We've done this once already, and next year when we have more data and we have 2 years worth of data, we will see if the evolution is meaningful enough that we continue the same way, or if we need to make adjustments, then we'll need to make adjustments. And so after a full year's worth, when participants started coming for the second year, what we've done is we've created a summary sheet for each participant. So in order to provide them, their caregiver, and possibly a healthcare provider, a summary report of what we've seen so far, how it's changed. And the possibility also is that you don't need to necessarily repeat the same test that we've done for the study in your everyday care, let's say, or in your, not everyday care, but in your follow-ups with your care providers. Couple of very practical, one very practical aspect for our site, I need to really flag, because I know it's not necessarily a deal breaker, but it can be. Our site's administrative processes are very, very slow, and just heads up, the refunds are very slow. So that's something that needs to be planned out properly. But nevertheless, families have reported a very positive experience, I'm happy to say. So I really appreciate those of you who have gotten back to me with those types of comments. It was a pleasure to be with you for the day of the visit, and I really appreciate that that you got back to us with that. Finally, the site location information. So we have McGill again in Montreal, Canada. With my contact information, Dr. Bravermans, it's hard to see her email address, but in any case, these will be published on the GFPD website, and the recording, you can replay the recording and you'll see this as well. And then the same thing for Dr. Levin, his email address, you'll contact him. And then, if there's really an interest after the few questions and back and forth or whatever, then Dr. Levin will forward your information to the coordinator, and there'll be further arrangements gone through with Emily. That's the gist of it. In conclusion, I would thank our sponsors, the Canadian Institutes of Health Research Grant Agency, as well. I will thank you, the GFPD, for supporting our research by allowing us to present this to you and the families of the warriors. And thank you, the families of the warriors, for those of you who've already made the effort to come to us in Montreal. It has been a pleasure, and we really, really, really appreciate that. It's not easy to travel with your warriors, and you've made the effort, and we really appreciate it. And we really hope that the progress of the translation from the mouse model to the human model will not take too long, and that we can pay you back by having gene therapy to offer. And so we'd love to see you in Montreal and Rochester, and we hope that you have questions for us from here on, so that we can exchange on the subject of the study.
Thank you so much, Frederique, for that informative presentation. We are so grateful to have you and Dr. Levin here with us. I'm going to go ahead and encourage everyone to make sure they're getting their questions in that they have. Some have already sent some through, and just want to remind everybody that you can do that in the chat box, but you can also, there's a feature that says Q&A at the bottom beneath your webinar player window. You can click that. It allows you to submit anonymously as well.
Can I make a couple of quick comments?
Absolutely.
I happen to be Canadian as well, and I recognize one thing that may be a little confusing to the folks out there, that ZSD is the same as ZSD.
Yes,
Zellweger spectrum disorder. And it's important to note that, because we use that term generally, but this would include Heimler syndrome and other peroxisomal disorders, which are sometimes named differently than the Zellweger spectrum disorder. So don't let that confuse you. What's important is that you have a pathogenic variant to change in one of the genes that was mentioned, because that's one of the key kind of ingredients to be eligible for a study. If you haven't had genetic testing, we can arrange for genetic testing to confirm your type as well. We also in Rochester have I've been doing these types of trials for over 30 years. So we're very experienced with testing kids with special challenges like your warriors. We can make a lot of success, although not every kid is going to be able to do every test. We recognize that, and we're set up that way. So if you're concerned that your child won't be able to do certain tests, one option is to do tests under general anesthesia, and that is something that's provided for in this study, although we hope that it'll be not necessary in many cases because of the experience in doing kids awake. But you can always discuss it with us. When you reach out to us beforehand, we can have a conversation to make sure your kid's visit is as good as we can make it. So I'm happy to take any questions along with Frederique.
Thank you so much. And Frederique, if you could just move to the next slide for us.
Yeah.
Great. Thank you so much. And I really appreciate you sharing about the mutations, are also known as variants, because that was one of the questions that we had was, what happens if we don't know, if we have those identified, or what do we do? What are the steps to take? So maybe we can get some information out and share that afterwards with our families, so that if they do run into that situation, they can have that information on hand and start taking those steps. We did have someone that shared that they actually have seen you, Dr. Levin, with their son in years past, and they wanted to know if they've seen you before, will any of that information be beneficial to this study?
It depends on how long ago it was, number one. And as you know, these are diseases which change over time. We may be able to use some data points, but remember, this is a sequential study where we're going to want to see the child again to see where they're at. There are some tests in this study which may not have been done routinely on your child. And if you reach out to me by email, I can certainly go back to the record, see what's been done, answer that more specifically, and then determine whether something else needs to be done this time or in the future. And one thing I will say is that some of you have children who have been seen elsewhere at other sites. And sadly, most of the time, using data from other sites is a problem because we have a need for consistency, using the same machines at the same site over and over to give scientific validity to the study. But that's another question you could just ask when you reach out to us.
Thank you so much for answering that question for us. Another one just came in that I'm going to go ahead and say, do you have to have a certain degree of vision loss to be eligible for the study?
Frederique, you can take that, but basically the answer
I
is no.
I don't think so. But you have to have a gene makeup that suggests you will have at some point degeneration.
And that's one of the beauties of a study like this is because um, when you're doing something like gene therapy, and that's something we do a lot of, when you do something like gene therapy, you have to know, or it doesn't have to be gene therapy, stem cell therapy, drug therapy for any kind of disease. In order to measure the effect of that drug or treatment, one has to have certain markers to go by, right? If I use your heartbeat rate to test how a medicine that fixes your toenail works, it's not going to be a very good measure, is it? We have to have something specific to the problem. So it doesn't matter where you're at on the continuum of vision loss, as long as we can start you at a given point and then follow that over time. Then we develop to see what changes, how does it change, and then when we institute treatment, we know what to look for to make sure that change has been effective, hopefully positively.
Thank you so much. And to go back to the other, in speaking of the consistency of different equipment and the validity of the study, what if somebody started at one site already? They've already started this process in Canada, and now the new site is much closer. Can they switch locations?
That's an interesting question. I would say yes, um, because our studies have um, coordinated the type and the parameters of machines and so on and so forth that we're using. So I would think that that would be okay. And we have the faith and confidence in each other and the communication between the two sites to make sure we can ensure that. Uh, I think in other places around the country, it's harder to use there. You can't go somewhere else and have it done because it won't be monitored in the same way. But I think, Frederique, that they could do that if that was more convenient for a family.
That makes sense. Yeah.
And unfortunately, nowadays we have some concerns about crossing borders. And if crossing a border right now presents a problem that may not be a problem in the future, we can facilitate that.
Thank you. And you mentioned how some of the tests are clinically approved for standard care, while others are done only on a research basis. So, if a result from a test is found that has a current care option, would that be able to be shared with the family?
Absolutely.
And will there be time also to explain the findings during the time there? Was it just testing, or will there be time to sit down and learn about it? I think is what that question's asking.
Oh, absolutely. I mean, we're not. Uh, we don't want anyone at any point in time to think that we're just testers,
That's it.
collecting numbers. We're physicians and care teams. We have a Ocular team, and our business is about taking care of patients and their families, not just their eyeballs. So you'll have a clinical visit. You'll meet with us. You can consult with us, ask questions about anything as part of your care. If you
At McGill, you will meet both the ophthalmologist and Dr. Braverman as well. So you will have a chance to ask questions to both specialists. And Dr. Levin is lucky to be both specialists in one person. So that's perfect.
we have genetic counselors and we have anything you need. And if you want to combine a visit, let's say you want a consultation with our neurogenetics doctors, or you have another medical need that you want to be looked at in the same visit, we can coordinate all that. I think sometimes families think, oh, this is a research visit. I got to go into this little box in this little room and do just that. No, this could be a clinical care visit as well, and we're happy to provide that service, whatever you need.
Thank you so much. I know for as a family myself, as director of family programs, I really appreciate how much I have heard all evening long about just accommodating our families and really listening to our families. So thank you for making that effort. We do have another question that's asking about the color test slide, and what if your child's unable to communicate or tell colors?
Why don't you go ahead, Frederique?
So for children who are not able to communicate, first of all, some of them it's through sign language, which I don't read, or nor do any of the people involved. So then the parent will be the translator, obviously. But if there's really no communication, there are tests that we will not do.
I will add this. A little piece of trivia. Did you know that the University of Rochester has the highest number of sign language translators in the entire country for an academic center? That's because of our affiliation with the Rochester School for the Deaf. We have 40 different sign language interpreters at Rochester. It's really a great thing. And the Usher Syndrome Conference was just held here. So if communication is a problem, we can always facilitate that as well.
That is great to know, and I think that's especially great for the families to know. Maybe that could help their decision in the discussion of which location they go to, of making sure that they have those accommodations and supports in place. And I just want to give a moment to see if there's any other questions that are coming through. And it looks like someone has been in contact with the McGill team.
And I would also add, please feel free to reach out to McGill or to Rochester by email and ask any questions. You don't have to make an appointment. You don't have to roll. If you just got a question about peroxisomal disorders in general and you want to know, we're happy to answer those questions.
Thank you so much. And that this is this actually you kind of answered without even knowing. It's like you had a crystal ball on that one. This person wanted to know about who they should reach out to if they need to be referred if they've already been seen at the McGill location. So I would
Can we
even say,
put that slide back up?
so I would say email these individuals and they will make sure to coordinate and help you. But
Absolutely. Yeah.
as also, if you want to go to the last slide in a moment, and just leave this up for another moment, and then we can go to the very last slide, Frederique. And just know that you can always reach out to the GFPD too. We are always happy to coordinate and make sure that you're getting connected with the researchers. I don't see any other questions go through. I'm just going to give it one more moment and make sure there's no others coming through. Great questions, great presentation tonight. Thank you, Dr. Alex Levin and Frederique, for being with us, for sharing with our community, for the crucial work that you both are doing to help those with peroxisomal disorders and those with vision loss. To our audience, thank you. This webinar and the slides again, including that contact information she just shared, that is all going to be available on the GFPD YouTube channel. But you can always, again, reach out to the GFPD. You can even just go to our website, hit, contact us. It's going to come to Ryan and me, and we're going to make sure that you get connected to the right people. So please make sure you also stay up to date. On the screen right now are different ways that you can stay up to date with the GFPD. There's a QR code. It will take you right to the GFPD directories. That's how we make sure that we can stay in touch with you and give you updates about things like this webinar that are happening tonight. So we ask that you also take a moment to complete a survey after this webinar. And if there's no further questions, I thank everyone again. Thank you, Dr. Levin. Thank you, Frederique, for being here. Thank you to our global community. And I hope everyone has a great evening.
Take care. Thank you.
Thank you.